Good morning, ladies and gentlemen. Welcome back to the day 2 of International Postgraduate E-Symposium 2021. Hi, my name is Lau Junsin, your MC for today. Let's start our program with a plenary speech from Dr. Yodi Mahendradhata, the Vice Dean of Research and Development, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia, with the topic Ensuring Continuity of Essential Services During the COVID-19 Pandemic. For this session, I would like to pass the virtual stage to our moderator, Associate Professor Dr. Wan Amir Nizam Wan Ahmad from Biomedicine Program, School of Health Sciences, University Science Malaysia. Please welcome Dr. Yodi Mahendradhata and the moderator, Associate Professor Dr. Wan Amir Nizam Wan Ahmad.
Okay, thank you, Chairperson. It is my great pleasure to introduce Dr. Yodi Mahendradhata. He is currently the Vice Dean for Research and Development at Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia. Dr. Yodi is a medical doctor by training.
Memang Dr. Yodi punya line putus-putus.
Hello? Okay. Dr. Yodi is a medical doctor by training, and he obtained his master's degree in international health from the Institute of Tropical Medicine, Humboldt University, and Dr. Yodi completed his doctorate in medical science at the Institute of Tropical Medicine and also Ghent University, Belgium. He is currently leading the Southeast Asia Regional Training Center for Health Research that is supported by TDR. He had led development of national strategy for implementation research and tuberculosis control, and also the country proposals to the global fund to fight AIDS, TB, and malaria. Dr. Yodi research interests are in the fields of global health, implementation science, disease control, health policy, and health program management. He was an Alexander von Humboldt Foundation visiting scholar at Institute of Public Health, Heidelberg University, Germany. He has published many journals in reputable international journals. He has been awarded as the Scopus Young Scientist Award by United Nations University Elsevier and Alexander von Humboldt Foundation. Mr. Yodi has been elected also as a Fellow of the Royal Society for Public Health since 2018. And with that, it is my pleasure to welcome Dr. Yodi to give his talk on topics of ensuring continuity of essential health service during the COVID-19 pandemic. Dr. Yodi, the floor is yours.
Thank you very much, Doctor. Can you hear my sound clearly?
Yes, Dr. Yodi.
Okay, let me check my share screen first.
Yeah, we can see your screen, Dr. Yodi.
Okay, great. Thank you very much. Okay, so Assalamualaikum warahmatullahi wabarakatuh. A very good morning, everyone. Selamat pagi. So today I would like to discuss with you this issue of ensuring the continuity of essential health service during the COVID-19 pandemic. Now, as we all know, we are still in the middle of the pandemic, and we don't really know until when. All we know is that it's still ongoing, and we've been going through several waves at the global level. And similarly, also at the country level, if we look at the situation in Indonesia, it's pretty much the same. It's still ongoing, and we're actually experiencing a surge at the moment, and we don't know whether there's still going to be another waves or more waves to come in terms of the COVID-19 cases. Similar, I think, in Malaysia also, in terms of absolute number, it's lower than Indonesia, but in terms of pattern also, you could see that you are also experiencing a surge in the recent weeks, and that we also don't know exactly how things will evolve in the coming weeks or months to come. So we are all very concerned about these waves of COVID cases and also death. But unfortunately, those are not the only waves that we should be worried and that we should anticipate. Now, here I'm talking about a much bigger wave. It's even, some people call it not a wave, but a tsunami. It's a tsunami of other health conditions, particularly chronic conditions, which we will see will increase in terms of burden of diseases, in terms of death, disability, and so forth, because the services for these conditions have been disrupted during the COVID-19 pandemic. And here, this include, for example, cardiometabolic diseases. This include hypertension, obesity, type 2 diabetes. All of these are at the crest of an impending tsunami because a lot of these cases are not being well managed at the moment. And that's why we are very concerned about this. At the moment, we are working with the Asia Pacific Observatory hosted by WHO to prepare a cross-country study to be able to see what's happening in the different countries in the Asian regions in terms of the impact of COVID-19 pandemic on these essentials public health programs, and also to see what are the lessons learned and what are the strategies we need to put in place. But that particular study is still in preparations. We are still developing the protocol at the moment, so we don't have much to share in terms of the study. But nevertheless, while preparing, we are compiling quite a few reports, quite a few data, background data, which I think it's useful enough to share in this forum so that more and more people in the region are more aware of the issue and also contribute to anticipating this issue, that it doesn't really become a tsunami that we're all worried about. So here I'm going to share some of the background reports, background data, which we have compiled in developing the protocol, which we will be carrying out in the coming months. So let me start with this report, which is from the high-level panel, the Independent Panel for Pandemic Preparedness and Response. And there you could see that in the beginning of the pandemic, many countries already reported disruptions. So here, for example, you see that many countries reported disruptions in the beginning, but here you see the disparity that globally we have 105 countries who are reporting disruptions in services, but these are mostly low income and lower middle income countries. While if you look at the upper middle income country, if you look at the high income country, you'll see much less. High income country, only 4% of them are experiencing actually disruptions to their general services. They have disruptions, but it's minimum. While for the low income countries, you see 45%. So that's huge. That's 10 times more than the high income countries in terms of proportions. And so here you see the disparity in terms of the resilience of the health system across the context of social economic. So in high income countries, they are more well established, they are more resilient, so they are capable of minimizing the disruptions, while in low income country, including lower middle income country like Indonesia, we are much less resilient, so we are experiencing more severe disruptions to our health services. And what services are being disrupted globally? This is from the report, and you can see there is a wide range of services which are being disrupted. On the top, you could see mostly dental services. I haven't been to a dentist also for 1.5 years because people are avoiding dentists. So that's number one, which is being avoided. And then you have rehabilitation services. That's worrying because that's quite needed for the elderly, for strokes, and so forth. But mostly it's disrupted. Routine immunizations, NCD, family planning. It's also being disrupted. And there we are actually at risk in terms of population control because our family planning services are being disrupted, and many more. Yeah? Now, if we unpack that a bit, so in terms of NCD, for example, non-communicable diseases, which are being mostly disrupted, again, is the rehabilitation services. And this is also, again, worrying because this is especially for the elderly, especially for those suffering from stroke and other diseases which requires rehabilitation. But you also have disruptions for hypertension, diabetes, and almost all categories of non-communicable disease services. In terms of communicable diseases, here the big three, TB, HIV, malaria globally. So in the beginning, all three were at high risk of disruptions, but they have recovered somewhat, that they're now at a moderate risk in terms of disruption, especially malaria. They seems to be doing pretty well in terms of improving things, while for TB and HIV, it's still relatively at higher risk than malaria in terms of disruption. Now, WHO have done two surveys, and just a couple of months ago, they released the second survey, and this confirmed that even though after 1.5 years, even though a lot of countries have tried to make efforts to recover, 94% of countries are still experiencing disruptions. Yeah? So only 6% of countries are experiencing no disruptions, and those are the high-income countries again. And in terms of the health services, if we look at the two surveys, what are actually being disrupted, here you see that it's mostly the primary care and again, the rehabilitation services. So those are the two main services which are being disrupted, primary care and rehabilitation services again. While in terms of program-specific areas, here you see that the program which is most disrupted is mental health, neurological and substance use disorder. And this is also a concern because we know during this pandemic, there is high stress. It's also quite difficult for the people to cope, to manage being in a lockdown, yet the mental health services are actually being disrupted. And then you have the neglected tropical diseases, and then below that you have non-communicable diseases and immunizations, which are being disrupted. Now, in terms of the non-communicable disease, here what is being disrupted, there you can see it's mostly the cancer screening, the hypertension management, diabetes, and again, dental care. So those are the non-communicable conditions, the services for non-communicable conditions, which are being broadly disrupted across the world. In terms of MNCH, maternal, newborn, child, and adolescent health nutrition, what is being disrupted? Again, it's mostly the family planning and contraception services which are being disrupted. But you also see disruptions in terms of malnutrition, management of malnutrition, and also disruptions in terms of sexual violence prevention and antenatal care on top of the list. In terms of communicable disease, here again, we see that malaria is pretty well off compared to the other two. So TB and HIV is more disrupted, TB in terms of diagnosis and treatment, and HIV in terms of testing services and HIV prevention services. So what are the reasons for the service disruptions across the world? Why are the services being disrupted? Number one, across the world is insufficient staff. That's number one. And why is that? Well, that's quite logical because most of the staff are being deployed for COVID-19 response. So they could not do their routine works. They could not deliver their routine services because many of the staff are being deployed for COVID-19 response. So they have to move away from the regular works. And also, we are quite aware that many healthcare workers are also getting infected by COVID-19, so they either have to be isolated or also they are hospitalized or they even passed away. So that's also aggravating the situation in terms of human resources. But that's the number one issue. Staffing is a major issue in terms of service continuity. Now, number two and number three is quite related. There is the decrease in outpatient volume. There is a decrease of patients presenting. But number two is quite concerning because it's about fear and mistrust. The fear is quite grounded because they fear in terms of contacting COVID-19. So they're afraid if they go to healthcare facilities, they might get COVID. But the mistrust is quite disturbing because that means that there is increasing mistrust from the community to healthcare workers, to healthcare facilities. We know there's infodemic out there. There's a lot of misinformation, disinformation conspiracy theories. Apparently, it's playing out in this phenomena in where there is increasing mistrust from the community to the health facilities, which of course varies. I don't know the situations in Malaysia, but in Indonesia, we see this. There is a increasing number of the populations which are mistrusting the healthcare facility and the healthcare provider, distrusting them. And there are others also in terms of financial difficulties and travel restrictions. So those are some of the issues why the services are being disrupted. Now, what have improved within this 1.5 year? Because they've done 2 surveys, so we know in terms of reasons there must be some changes. And so, what the good news is, the reason in terms of insufficient personal protective equipment, it has decreased. So, in the beginning of the pandemic, that's a major issue. That a lot of health facilities did not have enough personal protective equipments, but apparently across the world now that has decreased almost half. So that means we're doing better, even though it's still an issue. We still have a stock out in terms of personal protective equipments, but it's improving. Also, unavailability and stock out of health products. That has also decreased almost half. That's also a major issue in the beginning of the pandemic, but after a year, it seems most countries have made efforts to ensure the availability of stockouts, availability of health products. Even though again it's still there, but it's reduced in terms of significance. So that's good news, and hopefully that will continue to improve. Now, what are the things which have been done by countries to overcome disruptions? And here you see the list out of the survey. And number one, there's a lot of efforts and community communications, because there, we remember, it was a lot about fear, a lot of mistrust, and that is being picked up also by a lot of ministries of health. So a lot of efforts are being put into community communications. There's also efforts of triaging to identify the priorities, and also recruitment of additional staff, because again, staffing is an issue almost everywhere. And then redirection of patient to alternate care sites so that they don't pile up, accumulate in particular sites, and also provision of home-based care. So those are the main approaches which are being done apparently in almost every countries. Now, there are also some novel approaches, for example, in terms of prescribing and dispensing medicine, supply chain, and telemedicine, but it's still only in limited number of countries because there are some barriers in terms of implementing these novel approaches. Here, for example, in terms of telehealth technologies, it's mostly used for scheduling appointments, for primary consultations, pharmacies, and chronic care consultations. But there you see on the right, it's mostly, again, the one which is using it, which is reporting it, is the high-income countries. So 96% of the high-income countries are using telehealth technologies, while for the low-income countries, it's only 29%. So it's much lower. So obviously, there are barriers to use telehealth technology. And here are the main barriers which are being reported. So there is limited access to these technologies for patient and providers, especially in low-income settings. The internet infrastructure, for example, the internet access, the access to smartphones, for example, that's also an issue. But there are also limited technical capacity for clinicians to use. So not all health systems have that ready capacity to move the services online to telehealth. And there are also some limitation in terms of the knowledge and awareness of patients, but also providers in using telehealth technology. And that's also a barrier, particularly in the less developed settings compared to in the high income setting. So that's why telehealth technologies are not yet optimized in terms of the adoptions, especially in less developed settings. Now, let me just zoom in into Indonesia just to give you an idea what's happening at the country level. Unfortunately, I haven't managed to pull out the data from Malaysia, so I will just share with you from Indonesia, and perhaps in the discussions you can share how do you see it compared to the situation in Malaysia. But again, in terms of Indonesia, we are experiencing a recent surge in terms of the cases. It's going down in the past week, but we don't know yet. Hopefully, it's really going down, whether it's a transient reduction or whether it's really going down. But in terms of death, it's still increasing. We're the highest in the world at the moment, exceeding Brazil just recently in terms of mortality per population. So what's happening in Indonesia in terms of disruptions? It's actually quite serious. Here, for example, you see the disruptions increased 13%. Now, 89% of our essential health services are being disrupted, and this is higher than the regional or global average. Regional global is 36.8 to 38%, while Indonesia, 89% of the essential health services is being disrupted. And here you see, in terms of the service group, I mean, all of them seems to be disrupted except the auxiliary services. And you see it's mostly red, be it primary care, emergency care, rehab, reproductive, immunizations, non-communicable diseases. And if you look at the delivery channels in terms of primary care, what's being disrupted? It's mainly the health promotion and prevention services. So it seems like a lot of the services which are being maintained are more of the patient, more of the interactions, more of the healthcare. But in terms of public health, it's mainly being minimized in terms of health promotion effort and prevention services. So more than 50% is being disrupted. Immunization is also being disrupted, less than health promotion and prevention services, but also more disrupted than what's happening in the rest of the region. In terms of reproductive health, maternal, child, and adolescent health, this seems to be relatively well managed compared to the other services. So it's not doing too bad in term comparison to the region. Communicable disease, here we see it's worse than the maternal and child health. HIV testing services, ARV, initiation of new airway treatment, that's more than 50% disrupted, and that's worse than the remaining countries in the region, and also in terms of outbreak detection and also TB case detection. So again, TB, HIV, those are more disrupted relatively to other health conditions. And in terms of non-communicable disease, there you see everything is disrupted. So hypertension, cardiovascular, cancer, diabetes, asthma, dental care, they're all disrupted more than 50%. And this is all much worse than what's happening regionally or globally. Mental health, here it's a bit elusive. I mean, if you look at it, it seems like we are doing okay, but the reality is that we don't have much mental health program in Indonesia. It's still in its infancy. So of course, if you look at it, you don't see much disruptions because it's actually not there yet at an optimal scale. So we don't capture much in terms of disruption. But one which is being captured, which is quite worrying, is the school mental health program, because that's actually quite important nowadays. With a lot of the students are actually not going to schools physically, but doing everything online for over 1.5 years, and that is also mentally quite challenging. Yet school mental health services are being disrupted. So that's a major issue that we need to worry about in the coming month. And the reason for disruption, here you see there has been some improvement in the previous round last year. There's a lot of closure of outpatient services. Now they're being open, so no longer an issue. What is still an issue, what is still persisting as an issue, is staffing, insufficient staff. Again, it's everywhere. Huh? We also have this in Indonesia, and it hasn't improved even after 1.5 years. Most of our staff are still deployed to COVID-19 response. So the staff for the other health services are lacking. And then globally, there was reduction in terms of the issue of personal protective equipment, but in Indonesia, it's still an issue and it's even increasing. Stock out of medicine is also still an issue. At the moment, we are very much in critical condition in terms of oxygen. A lot of our hospitals are in critical supply in terms of oxygen, and then also there's also disruption due of changes in treatment policies and care-seeking behavior. So those are the main disruption from the supply side. From the demand side, here you see again community fear and mistrust. That's a major issue. So a lot of people are still afraid in terms of coming to the healthcare facilities, and also a lot of mistrust. in Indonesia in terms of seeking healthcare. And then also, of course, also travel restrictions. Even though in Indonesia we never actually have a severe lockdowns, our restrictions are actually quite relaxed in compared to other countries, but still the restriction hinder access to the health facilities. And then in terms of health system and service responses, in terms of policies, at the least, it's all pretty much there. So we have policies which are in place. It's more of the implementations which is an issue. I think it's similar to many other settings that we have policies in place, but implementation is the issue. And then what are the approaches which have been adopted? And here you see we do triage, we redirect patients, we do telemedicine, self-care, and recruitment. What's not being done, which we really hope can be done soon, is task shifting, role delegation, because that's really needed to be able to overcome the human resource issue. We also haven't done much in terms of supply chain management and logistic, dispensing and prescribing approach. So those are the things which we really need to. Provision of home-based care also. That's something which we haven't really done much and which I think needs to get more attention in the coming months if we want to overcome or prevent this tsunami. And in terms of telehealth technology, a lot is being adopted, but there significantly missing is primary care consultation. So there's not much going on in terms of primary care consultation. Mental health consultations, again, is being neglected. Chronic care consultations is also not there yet, and eye care consultations. So those are conditions which we will have to worry about because they're not being taken care of, even using telehealth technology. And what are the barriers to this? Here you see it's mainly again funding, technical capacity, awareness, knowledge of patients, and also providers, and access to telehealth technologies. The remaining two, I a bit disagree because it says that we don't have problem in terms of security and privacy concerns. We actually do. I don't know why here it's not recorded as an issue. Legal or regulatory barriers, we actually do. It's a serious issue. We have legal issues in terms of telemedicine. We don't have a strong enough legal platform to actually conduct telemedicine. So this actually should have been an issue, but it's not recorded as an issue here. So to conclude, what are the key findings for the moment? So we see here over 1.5 years into the COVID-19 pandemic, substantial disruptions persist, despite there are some restoration, there are some recovery efforts. And countries in high income groups reported fewer service disruptions compared to countries in other income group. And overall, primary care, rehabilitative, palliative care are more affected. And this have serious implications for the most vulnerable populations, such as elderlies and people living with chronic conditions. And the service disruptions we're seeing are perceived to be caused by a mix of supply and demand side factors, depending which country this is happening. For example, globally, it seems like there is a reduction of disruption due to insufficient personal protective equipment and health products, but that's not what's happening in Indonesia. And there are a lot of strategies for restoring adaptive services which are being implemented by different countries. A lot of countries are experimenting, and many countries are using telehealth technologies to mitigate the disruptions. But limited access and technical capacities to use telehealth technologies are the most common reported barriers, especially in low-income countries, in less developed countries. And so what are the lessons learned? Number one, we really need to invest more in terms of preparing and protecting our healthcare workers because we don't have much, we don't have enough, and they are not sufficiently protected. Many of them are falling ill, hospitalized, passing away. So we need to protect them better. Otherwise, things are going to get worse, and we need to prepare them better also, train them, give them the proper equipment, the logistic. And there is a need for reducing the need for facility visits. This is where telehealth is actually important to minimizing visits, to minimize the burden on health facilities. Telehealth is also useful to reduce overcrowding. This also involves triaging patients, moving patients to other facilities. And surveillance system of essential health services needs to be strengthened so we know what's going on. So we know where the disruptions are more serious, are more severe. And these lockdown policies, we need more studies to actually look into the evidence on how we can actually deploy lockdown without impacting essential health service utilization. There is not much evidence on that, and that's a nice thesis or dissertation if any postgraduate would like to take up to see the evidence on lockdown without impacting essential health service utilizations. And last but not least, we need to ensure focus on equity in response and recovery, because what we are seeing, it's again, is the most vulnerable populations which are going to be severely impacted by this COVID-19 pandemic. So those are the key lessons which are coming out. There are more broader guidance from WHO. If you are interested here, I'm not going to talk about this in details, but basically there are many elements we need to think about if we need to maintain essential health services. So there are issues in terms of governance and coordinations. We need also efforts to prioritize and adapt essential health services so they can still be maintained under current conditions. There needs to be efforts to also to optimize the service delivery setting and platforms using technology and so forth. Patient flow need to be better managed. Health workforce capacity, that's always one of the main critical issue. Essential medication equipment and supplies in terms of supply chain and logistic. There needs a lot of efforts to ensure that. Financing of these services, because a lot of the funding are being diverted also for COVID-19. Communication strategies, monitoring of the services, and the digital platform for service delivery. And all of that, you can read more in the different guidance which has been developed by WHO. You can search this online. There is this operational guidance. There is this facility assessment tool that you can carry out in different settings. And there's also a result of the surveys to give you a background data, what's happening at the moment and what needs to be further assessed. And most recently, WHO also launched this Health Service Learning Hub, which is, I think, quite useful. And I would encourage you to have a look, to go through it, and so that more of us are more aware of the issues, more of us can also contribute to anticipating this issue, so that we are better prepared to deal with the tsunami when the time comes, so that it won't be a major tsunami as we all fear. I think that's it. I hope that's useful, and I would welcome any questions or any comments for the remaining minutes. Thank you very much.
Thank you, Dr. Yodi, for the very comprehensive sharing about the current situation of our actually a regional and also the global essential health service, whether disruption or the continuity. So I would like to open the floor to our participants. If you have any question or any thing that you want to share with Dr. Yodi, you can either ask the question. So unmute your mic, or you can also type your question in the chat. So anybody want to ask any question, you can ask Dr. Yodi now. Okay, I think let me start the ball rolling first, Dr. Yodi. So
Okay,
it seems that on this continuation of this essential health service, I just wonder what is your role in the COVID management in Indonesia then?
My role?
Yeah.
Yeah. So, I mean, as academicians, we have multiple roles in terms of the COVID-19 response. I myself currently Vice Dean for Research and Development. So my role is more in terms of the research support to COVID-19. While there's a broader role for the faculty, but my own role is more of trying to provide evidences to support COVID-19 responses. But there I also have this worry that we COVIDize our research, because many researchers are now converting to become COVID researchers. And then we also worried that we don't have enough research in the other health issues. So also in that sense, I try to make sure that in our faculty also, that our faculty members, that not everybody are moving to COVID, but we also still do research. We still also produce evidence in the non-COVID related issue, especially in these essential health issues, so that we don't neglect that, so that it doesn't become a big issue later on. So that's my role basically. So dual role in terms of providing advice also to the government. So they frequently invite us to consultative meetings, the ministers, and so on. They ask for advice, so we give them what is the current evidence, be it empirical studies we do or from the systematic reviews. But also in terms of this, this is one that we still need to advocate more in terms of essential health services. So at the moment, the government is still very much on the COVID. So also many of the advice they request is more of advices in terms of how we do this. I mean, how long we should do the lockdown, how extensive, how restrictive, and so forth. But we need to get more attention on the essential health services.
Right. So in terms of research, when you say about research, what about this, what I call facility for the students itself? Do the students have been allowed to go in to be there to continue the research, or how is it being managed in your faculty then?
It depends on what kind of research they're doing, because we have students in many different programs, for example. So I mean, whether it's a lab, it's clinical, or public health. So for most students, especially for example in public health, most of them are doing studies or their thesis project are converted into more secondary data, or they're working on big data which are available. So it doesn't require them to actually go into the field, because we do have quite a lot of data out there. We have a bank of data which they can work on. So that minimizes the risk of them going to the field, so that they can still do research. Also to do reviews, for example. So there's a lot of reviews which are being produced by the students at the moment, and that's the same which can be done also for the clinical researchers as well, the students, the postgraduate students, the specialists also, that they can do also do reviews and so forth. In terms of the lab, it's possible, but it's being limited, so it's restricted because there's a lot of restrictions. So that's the issue. Not it's not possible to cater for them as we do before the pandemic, but there is a possibility as long as they follow the procedure and as long as they're well supervised, and there's also some assessment that they have to do before they enter the lab. So they're being closely monitored. So that there is a disruption in terms of that. So if the students are lab based, there it's very difficult for example to do their lab research. Very few can actually do it. But if the students can actually resort to more of data which is available or do reviews, then they can proceed. That's what's happening in terms of the research for the postgraduate students.
Okay, Dr. Yodi, there's a question from the audience in the chat box. I read the question for you.
Okay.
Are there difference in terms of the magnitude of healthcare interruptions between countries that very much depending on the public service, like Malaysia, and countries that mainly managed by the private sectors, like the US?
Mm-hmm.
So there is a question from FY.
Mm-hmm.
Should I repeat the question, Dr. Yodi?
No, I got it. So they want to know whether there are differences between health systems which are mainly private, like the US, but also difference with the health system which are mainly public, for example, like Malaysia, perhaps. Yeah. So that's interesting. We do not have that comparison. That's what we are trying to do. That's what we're trying to carry out at the moment, which we're preparing the protocol with WHO at the moment. But in the surveys that I mentioned to you, it's not being looked at yet. So it's a quick and dirty survey which you saw. So they haven't differentiated yet. But we do see that on case-to-case basis. So, for example, we had colleagues from Japan, which also see that there they also have the private and public, and they see also the issues between how the private respond and the public response. For the private, for example, because there's an issue of maintaining their operations, there's a profit also issue which they have to be sure of. So there is much more consideration there, which is a bit more complex on interest to make sure that they don't collapse. While for the public one, because they're supported by the government, so there is much more support there in terms of ensuring that the service is being continued. While the private is, there is not much incentive basically. I mean, from the government to the private sector. For them to continue the essential services. So they have to do it by themselves. And that's what we see is a bit worrying. And that is actually in Indonesia causing a bit of mistrust. Because now people are thinking that this is profit making, for example, for COVID-19 testing, that it's high cost and that the private services are making money out of that. And also, just recently, for example, they tried to make the vaccines available from a private a channel that people can buy vaccines, and that is cancelled now because a lot of people are not happy because that's an issue of equity, and that also again promote this idea that somebody's making profit out of it. So that's another big issue that people here, I don't know in Malaysia, but in Indonesia, that's an issue that a lot of the community are suspicious that there are people making money out of this pandemic, especially from a private perspective. So that's something we also have to deal with, but we don't have much data on that. We want to have more data on that. We are preparing protocol, but at the moment, it's just more of this, case by case that we hear of, that we observe, nothing systematically yet to share at the moment.
Okay. Basically, in Malaysia, when you say about this vaccination, Dr. Yodi, actually the vaccine currently is available for free for everybody, but there's a what they call plan, if I'm not mistaken, that has come up that especially made available for the company side, say for example like factories, because as you know that in the factory there's a lot of foreign worker.
Yeah.
So I think that's why I think the government have a plan to come up with where the factory actually can buy for their worker, because currently the vaccine actually open up for the citizen of Malaysia. So for the factory, basically, I think there's a plan for the government sort of like to charge for the workers, especially for the foreign worker. In view of this, when you say about the facility, Dr. Yodi, are there any sort of like what they call, has Indonesia come up sort of like a full-fledged COVID hospital or sort of like field hospital?
Yes, we do have a lot. We have a lot of full-fledged COVID hospitals. The biggest one is in Jakarta. That's in the athlete village, which was used for the Asian Games. So there's a huge facility there. I think it's the biggest field hospitals that we have. Also in different places, like in where my hometown is, Yogyakarta, we also have several field hospitals. Again, that's because many of the existing hospitals are overloaded. They're overwhelmed, they're over capacity. So we need this additional field hospitals to be able to manage these other cases which are less severe. So the one which are having mild cases, mild symptoms, while the severe one, they still have to go to the referral hospitals.
Yeah. Any question from the floor? Anybody want to ask any question? You can unmute your mic.
Good morning.
Good morning.
Yes, go ahead.
I'm Natasha from USM.
Yes, please.
Okay, so I have a questions for Dr. Yodi. Dr. Yodi, I'm wondering actually how Indonesia do the modifications of service delivery to maintain essential non-COVID-19 services. Do you modify the service access, space, or delivery? How in general Indonesia modify service delivery to maintain essential non-COVID-19 services?
Yeah. So I don't know if you can still see on the screen, but that's what has been done by the government in terms of modifying the service delivery. So triaging to identify the priorities, and then redirection of patient to alternate care sites. Yeah. And then telemedicine again, so moving things online, even though again there were some challenges in doing that. self-care interventions, so making the possibility of facilitating self-care interventions, and recruitment of additional staff. So, for example, recruiting volunteers. So, for example, just last week we had a lot of medical doctors graduating, so we recruit them as volunteers to be able to help in terms of not just for the COVID-19, but also to be able to support the essential health services. And also the community communications, informing on changes to service delivery so that they don't get disappointed if they come because some services are not there or service hours are being modified, and there are also some misinformation. So those are the main things which are being done in Indonesia in terms of adjusting to this COVID-19 for the essential health services. And it's similar to what has been done in other countries. I'm guessing also you're doing similar in Malaysia, but I'm also interested to hear what's being done in Malaysia.
There's a question in the chat box, Dr. Yodi.
Yes.
It's from one. Some healthcare services are being jeopardized in order to fulfill the needs for the caring for the COVID-19 patients. And many individuals are afraid to visit healthcare facility for fear of contracting the virus. What are your thoughts on this situation?
Yes, that was one of the main issue, fear, the fear of patient to come to the health facilities. So that has several dimension to it. So if you want to make them not worried, then we have to convince them that it's safe. That means also it's on our side to be able to ensure the safety. And that's something which is not easy also. I mean, we see, for example, in Indonesia, in terms of personal protective equipment, we still have an issue in terms of the supply. I mean, we have to have that in place if we want to say to the patient that it's safe, that we have enough personal protective equipment, that infection control measures are being taken. So we need to have all of that in place because before we can actually convince the patients that it's actually safe to go to healthcare facilities, that we are managing the patient flow and so forth. And that's still a work in progress in many facilities in Indonesia, that we try to convince patients that it's okay, it's safe, especially for the emergencies, for the urgent needs and so forth. And also in terms of communications, that's where the heavy work is also coming, because there's a lot of disinformation, misinformation, especially through the social media, and that is not easy at all. So I think those are the main two. So the first is ensuring the safety itself in healthcare facilities. And the second one is the communications, which we are all still experimenting on how to best convince the patients to reduce the misinformation, the mistrust, and so forth.
Sure. I think the misinformation actually is because of a lot of being posted in social media actually, and
Yes.
it's been uncontrolled actually.
Yeah.
With regards to this, it's very alarming, isn't it, to see the increasing case, as you put it, nearly more than 3 billion, million actually, sorry, in Indonesia. And in Malaysia, actually, also the cases actually more than 1 million currently.
Yeah.
So in view of that, there's question in the chat box. Can you share a little bit about vaccination plan in Indonesia? Because we know Indonesia has a lot of regions. They are very difficult to reach. Thousands of islands, and some of them take hours to reach in. That sounds very challenging, actually, for the Indonesia, actually. So what have been done about this plan for the vaccination in Indonesia?
Okay, so in terms of vaccinations, I think we're among the first few countries which started vaccinations quite early in January, early this year. And we were fortunate to be able to secure from China the Sinovac vaccines, quite large amounts of doses, even though admittedly from the data it's less efficacious compared to the other vaccines, but at least we managed to get a huge bulk and distribute them quite rapidly. So, for example, in terms of healthcare workers, they're practically all vaccinated for even to the second dose. So, and we are actually starting the third dose now. So, we're starting booster for the healthcare workers with Moderna vaccines, no longer with Sinovac for the third dose. So, for the healthcare workers, in terms of vaccinations, pretty much well covered. Then we also went to the elderly. That's more challenging. to be able to reach the elderly because of various issues, as you can imagine. So we're not doing well. Here, we're not even talking about geography yet, because even though it's true, Indonesia is a huge archipelago with 17,000 islands, but most of the population are in Java. So about 70% of the population in Java, but even in Java Island, where geography is not an issue, it's not easy to reach the elderly and also the informal sectors. That's not easy also. So even in places where geographical access is not an issue, we still have a lot of issue in terms of distributing, in terms of the logistic and so forth. At the moment, what we are managing is 1 million dose, 1 million vaccination inoculation, per day, and the president wants it up to 2 million per day within this August month. So we're trying to increase that, and the target has increased also. Previously, we were only aiming to vaccinate 180 million. By 2022, but now the president wants it to be 200 million something, I forgot, by the end of this year. And that's because of this urgency, but also because now there are some evidence that the vaccines are safe enough for the adolescents. For the young adults. So then that becomes part of the target now, and it's starting already. My 2 children in secondary school have been vaccinated. So there is also an increasing coverage of school children for vaccination. But the geographical issue is valid, even though it's not for the majority, but it's an issue. Especially also for the vaccines which requires cold chain, which are a bit more demanding. I'm sorry. For the Sinovac, it's not so much an issue in terms of the cold chain because they are not so demanding in terms of temperature. But for the others, if they come, then yes, that will be an issue, especially for the outside Java.
Yeah, sure. Any more question from the floor? Anybody? We only have, say, 5 minutes more for Dr. Yodi.
Assalamualaikum warahmatullah.
Yeah, go ahead.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for your sharing. My question is, it has been a long battle for the healthcare system in managing COVID-19 and as well as maintaining day-to-day task of managing health. So I bet it has been a very stressful situation for them. Is there any strategies put in place in Indonesia to cater for the mental well-being of the healthcare professionals there?
Yeah. So that's a very important question. Now, if you let me go back here. You've seen the issue here. And I mentioned in the beginning that our mental health programs is not yet well established. And here also, it's not well covered. So even in the telehealth technologies, mental health is the one which is missing. Yeah. So there are efforts to provide, to connect health workers with mental health services. But our capacity to provide mental health is also limited. So it becomes a catch-22 because then, okay, I mean, you want to provide, but even our own capacity to provide mental health is still limited. So the intention is there, the program is there, but the capacity to carry out is still limited to provide this even at the moment. So that's the problem. There's a gap between the intention, between the program and the capacity to actually deliver sufficient mental health services for healthcare workers.
We have one more. Any question from the floor? One more question. Anybody? Okay, so we have the full-fledged hospital in Indonesia and also field hospital. Say, for example, what about, say, those who, say, have mild symptoms of COVID? So how actually they've been sort of like isolated from the others? Do you have a system like they sort of like have this home quarantine or any sort of like facility for them to be quarantined in one place other than for say, for example, for stage 1 and stage 2?
So we are now pretty much advocating for community shelters.
Okay.
So the shelter, because what we see is that the home quarantine is very much risky.
Yeah.
Most of the population do not have houses, homes which are safe enough for home quarantines. So we had that policy in the previous year in terms of home quarantines, but what we see is increasingly household clusters. So a lot of people in the homes were being infected. So now the policy at the moment is tried to advocate people to go to community shelters instead of home quarantines, where they'll be taken care of. But that's also another challenge to be able to manage these community shelters. Again, they have to be staffed also. They have to be managed also. So it's something which is still being prepared and or some are already operational. But in terms of capacity, it's still something we're trying to increase now and then. But that's the policy to move people to community shelters instead of relying on their homes, which in most cases is very risky.
Yeah, sure. I think that's the only time that we can have for the question and answer. So, Dr. Yodi, thank you for
Thank you.
your excellent sharing. And also, oh, actually, there's one more question. Can we?
Sure.
Okay.
Sure.
From the floor, ensuring essential health service during the COVID-19 pandemic is critical. What is our public to help in ensuring essential health service, particularly for those from low and middle income facility? So
Could you
what is
repeat?
our role to help to ensure the essential health service? I mean,
What
our
is the
role,
role?
our public to help actually to curb the what you call situation, to help
Okay.
how the government to
Mm.
ensure the essential health service being delivered for others.
Yeah, okay. So there are several laws from the public. First of all, is to advocate also to advocate this issue. This can be done by the public because most governments are very much focused on COVID-19 response, rightfully so, because that's what's on the table. So they often do not have enough bandwidth to actually think about the essential services. So there's a role of the public to actually advocate for this, so that the government doesn't lose sight, or that this at least get enough attention for them to invest, also to allocate resources on. I think that's the main things. The other thing is also to be able to provide alternative services from the public, which can be done. I mean, there are some health services which can be carried out by the public, can be organized by the public. I mean, in terms of health promotions, in terms of health preventions, and these kinds of things can actually be done by civil societies. It doesn't have to be coming, for example, from the government, and that can also be provided, and that helps to alleviate the burden of the government to actually deliver all of these health services. So the public can actually have a look at where are the gaps now and what can be provided from the public without needing government support or license or anything, because there are some of the services which can actually be done by the community, by the public. So those are the main two things, I think: advocating and also looking into the gaps in our own communities, what is missing. I mean, for example, the shelters that I was talking about, many of them are community initiated. I mean, it was not from the government, but the community actually initiated that, and of course at the end they get government support. But there's a lot of things communities can do bottom up, not waiting for the government to actually take the lead.
Yeah. So to recap what Dr. Yoda says, I think for us as the community and the public actually to keep our trust in the government to help to manage the situation of the COVID, and also to keep our trust and also our sort of like effort also needed, our own effort also needed to help to curb the situation currently. So I think that's all for talks by Dr. Yodi. Thank you very much, Dr. Yodi, for very comprehensive and also sharing on the current situation to all the viewers. And I think by that, thank you very much, Dr. Yodi. So, Assalamualaikum. And
Waalaikumsalam. Thank you. Thank you very much, doctor. Okay. Thank you, everyone. Take care. Stay safe.
Rajun, you
Sorry. Thank you, Dr. Yodi Mahendradhata, and the moderator, Associate Professor Dr. Wa'ame Nizam Wan Ahmad. It was a very beneficial sharing session for us. Ladies and gentlemen, after the speech given by the plenary speaker, now is the time for all the participants to get ready for the research presentation. The concurrent oral and poster presentation sessions will begin at 10:30 a.m. sharp. So all presenters kindly proceed to the respective breakout rooms via the link provided, and please do not be late. For oral presentation, in total, we have 5 rooms. Room 6, Medical and Health Sciences in Clinical Research. Room 7, Medical and Health Sciences in Community Studies. Room 8, Medical and Health Sciences in Molecular and Cellular Biology, Biochemistry, Microbiology, Immunology, and Genetics. Room 9 and 10, Pharmacology and Toxicology. For the poster lab presentation, please enter room 11. Thank you and all the best. Our plenary session will resume at 2:30 p.m. We will have 2 concurrent plenary speech sessions by Associate Professor Dr. Mazam Muhammad from University Malaysia Kelantan, UMK, Malaysia, and Associate Professor Dr. Warakon Limbut from Prince of Songkhla University, Thailand, via 2 different links. We will update the link for the sessions in WhatsApp group as soon as possible. We kindly request you to fill in the feedback form for the plenary speech session via the link provided in the chat box. Thank you and see you all soon.